Good morning. It is 10 o'clock in Pittsburgh, likewise in Kentucky. My name is Barry Schaitkin. I am a elderly ear, nose, and throat doctor from the University of Pittsburgh. I am the residency program director here and a recent past president of the program directors organization. So thanks, Brett, for doing this. I've done all three of the different courses at this point. I am part of a group that would love to see this continue, at least in some fashion, for people around the country, big programs, small programs, to have the ability to log in and see what's going on at different centers, different philosophies, what have you. I wear a bunch of hats at Pittsburgh, and one of them is salivary endoscopy. So salivary endoscopy has taken off at most academic centers, I'm sure. But this is sort of just an intro thing, not knowing who the audience is and what you already know. I'm kind of a fan of history, so I'm going to talk a little bit about history and then some of the other aspects of the disorder. History for me starts with Stenson. So Stenson, was a scientist at a time like Benjamin Franklin or Thomas Jefferson, where you could really know all of science, okay? And so Stenson was known as a really incredible anatomist, but he's most famous for his geology work. So one of my favorite books in this regard, because if I wasn't a ear, nose, and throat doctor, I probably would have been a geologist, is The Seashell at the Top of the Mountain, okay? So this is the story of Stenson from a geologic standpoint primarily. So Stenson is well known in geology to the point where on his 374th birthday, he had his own Google Doodle, the thing they put out every day. And the question that Stenson was troubled for a long part of his life with was, why are seashells often found far from the sea, embedded in rock at the tops of mountains? And all the time you had to do this in a way that did not offend the church at that time. So science, had different connotations. Stenson did figure that out. He did figure out that they weren't falling from the earth as stones, which was one of the prevailing theories. He did figure out that it wasn't Noah and the flood and the ark. So, very interesting guy. From our standpoint with Stenson's duct, Stenson was a student of anatomy. He was working with Bartholin, also, an ENT famous anatomist. And there was a war at the time, and he didn't really learn much from Thomas Bartholin. So he went to study with this guy, Blasius. And he got there, he brought his own sheep's head. And while he was looking around various orifices of the sheep's head, he entered a long duct that he had never heard of and that he couldn't find any reference to. Even Wharton had recently published his work on the submandibular gland, and yet there was no mention of this structure. So he dissected it with care, and he tried it on a couple other animals and found it to be in existence. So he went to his mentor, Blasius, and he said, hey, I've found this thing. And Blasius basically told him that he created that opening. He was like traumatic, putting the probe in the mouth. He was supposed to be this great anatomist. How disappointed Blasius was with him. But he told a couple of his friends, and they not only repeated it, but they named it after him. So Blasius, being a successful mentor, saw this excitement about this new discovery. So he went and repeated the observations, and he got some of his friends to confirm it. And then he put it in his own textbook as his own finding. Steno eventually would leave science behind. After all that time of trying to get along with the church, he actually joined the church, and in the 1980s, he was beatified within the Catholic Church. Wharton lived almost, as I said, about the same time. He published at his own expense this monograph that I have this terrible picture from Google about the face cover of it. Was all about the submandibular gland, but it was titled at the time, Glands of the Body. Bartholin also had another son who published extensively in the salivary world. He was apparently got trapped up in issues of nepotism. At 13 years old, he published a dissertation on the anatomy of the swan. And then he received a professorship at 19. And eventually it did come out that his father had written the story. All right, my own story of salivary endoscopy begins when I was a resident. In 1989, Philip Katz, who is still lecturing on this topic, was giving an academy course on salivary endoscopy. And I was a chief resident in 1989. And I came home and I said to my chairman, this is the coolest thing I've ever seen. We got to start doing this. So that was 1989. And it wasn't until 2005 that the FDA of the United States approved the technology and we were allowed to start doing it. So I started that immediately as soon as the FDA approved it. I started doing it in 2005 because I've been wanting to do it for 20 years. So it gives you some idea of the timeline of the technology that's been out there. This guy, Philip Katz, is actually a radiologist who, you know, is a big name in salivary endoscopy. Eero, another huge name, has published a lot of the work that we have on lithotripsy, which we'll talk about a little later. Marshall, who I learned from, another huge name, is in, so Eero's in Germany, Marshall's in Geneva, Switzerland, and he developed with Karl Storz the most of the equipment that I use today, although there are other sets out there. 2004, Zenk, who was part of the Eero group, developed their own semi-rigid scope and published extensively. So the main groups that you're going to see publishing the initial work on salivary endoscopy and how we all got started are Katz, Eero, Marshall, Zenk, and Nachlili from Israel. And Nachlili also had a big series by 2006. You know, several of these people have gotten together, along with McGurk, who's out of the UK, and you see Katz's name there again. But this was, you know, in 2009, you know, a series of about 5,000 patients. Because Europe and Israel were way ahead of us for the reasons I talked about with the FDA and all. All right, when you're first starting to think about, you know, what can I accomplish with these telescopes within the ductal system, you have to think about what is the actual size of the duct. And Wharton's duct has a diameter of about 4 millimeters. So that gives you some idea when you're looking at a stone, how likely is it that this stone is going to come through the duct, right? Stenson's duct is even smaller, about 3 millimeters. You know, both of these you can get intraglandular, especially the parotid. You can get well out to the lobule of the ear with scopes that we use. The scopes that we use, I didn't talk about the scope very much, but it's the workhorse is probably the 1.3 millimeter or the 1.1 millimeter scope. The 1.3 is Marshall's workhorse scope, I would say, and 1.1 is Eero's workhorse scope. And I have both of them. Each scope has its own toys that go through it. Each scope is limited what it can do based on that. Bartholin's duct, there you go, going back to Bartholin. Bartholin's duct is currently not something you can put a scope in. This is a stone in the sublingual gland that can't be accessed that way. All right, the epidemiology of stones, there's a lot of papers out there. The range is fairly large, but you know, in Europe, I would say 1 in 15,000 is probably the most reasonable number out there. Autopsy studies, like when you look at thyroid nodules and the incidence of thyroid cancer in autopsy studies, if you look at that for salivary stones, maybe 1% of patients will have some type of stone, realizing that, you know, we're not going to talk about the etiology very much, but a lot of patients, in these autopsy studies will have what are called microliths. And microliths are, as you can imagine, very, very small crystals within the saliva. And a lot of people feel that these microliths are what then over time become the stones. So that, you know, a huge number of us have microliths, but a smaller percentage will actually get a salivary stone. What are the stones made of? You know, the only reason to know this is that your patients will ask you, what is my stone made of? And you can see all the salts listed here. This is a good paper from a long time ago. Why do I not think it matters too much otherwise? Well, by and large, we don't even send these stones out for analysis. You know, kidney stones get sent out because there's a subset of kidney stones that you can do a dietary adjustment and not have the risk of getting future stones. We don't have that for salivary stones, so we don't know what to do with the information if we get it. So in that regard, we generally just throw the stones away. The stones, you know, so a little bit about CAT scans and stones, or CAT scans and inflammatory salivary disease. CAT scans probably still in the United States the biggest indication for the biggest used radiologic investigation for this, but we'll talk about all the different things. You can see in an enhanced CAT scan, you can sometimes get a sense of ductal dilatation. Obviously, stones show up. Let's just say a word about that. I frequently will get a referral for non-opaque salivary stones. So non-opaque salivary stones, that is a holdover from my residency when we did plain films looking for salivary stones. For CT scan, there really is essentially no non-opaque salivary stones. There is, you know, a certain size that you have to be recognized on a CAT scan, but most symptomatic stones will fit that size criteria, meaning they'll be bigger than 2 millimeters. So I don't think we still talk about radiopaque and non-radiopaque salivary stones like we did in the plain film era, although people still quote that literature as if it's for CAT scan, but it's not. Invasive sialogram is not performed all that much. However, there are certain centers that do it every case. Like I know the University of Iowa and Harry Hoffman is a big sialogram fan. I do use it for patients who I cannot figure out what's going on. I still find that it's sometimes useful. There's only one radiologist left in Pittsburgh who will do it. So you have to get in with Char Brandstetter if you want to get a sialogram. Nobody else will cannulate the papilla. I would encourage you to look back at some of the work that's been done out of, again, Geneva, Switzerland. Dr. Marshall's radiologist is Minerva Becker, and all the work being done with MR and salivary disease came out of her work. And so if you want your radiologist to learn how to do MR sialography, which we're going to talk about briefly, you know, they need to go back and look at how do you do it from some of these papers. In terms of how sensitive is MRI to the various pathologies they have looked at, you can see for stones, sensitivity of 91%, specificity of 94%. By and large, you know, missed some small stones like we talked about on CT. Very accurate for stenosis. This is what an MR sialography looks like. So first of all, what is it? MR sialography is a non-contrast MRI, okay, that is adjusted to bring out these images, and these images are using the saliva itself as the contrast. So no injection into the duct. This patient has a bilateral parotid megaduct, more apparent on the patient's left. And this is, you know, what you see is these massively dilated ducts out in the face as well as into the glandular elements. And this can be seen very nicely with MR, but MR can be used to be, you know, for more subtle findings as well. It's just I put this patient of mine up because it's so dramatic. So what imaging do you use? You know, it sort of depends on what you're looking for. I would say for CT, for my hands, and you know, at Pittsburgh, I use CT for most inflammatory disease, MR for tumors, MR sialography instead of sialography for problematic cases, difficult diagnoses. In the US, the ultrasound is rapidly replacing CT for inflammatory disease. The centers that specialize in ultrasound, you know, pretty much just use ultrasound. I do have ultrasound in my office. I use it more as part of my physical exam. I'm not as comfortable as, say, Arjun Joshi in Washington, or Will Ryan out in San Francisco, Trevor Hackman at UNC, but I do use it, but I use it and often with a CT scan as well if I have any questions. So when you get started, you need a couple of things to get in a look at the mouth. So if you're doing it in the office, which a number of people do it in the office. I don't personally do it in the office, but if you're doing it in the office, the patient's awake, obviously, so they'll hold their mouth open. Magnification in the office can either be with loupes or with the, a number of people will use the microscope in the office to cannulate the papilla to get started. Lighting is very important. And at the beginning, you want to be very, very gentle with the dilators, as well as touching anything like with a tooth forceps that might give the illusion of what Ricardo Corral at Ohio State has called pseudo orifices, where you make a little stab with your dilator, and now it looks like that is the papilla. So be very, very careful with all these kinds of things in the beginning until you get this started. We wrote a paper way back when we got started with this on getting started, the learning curve, and a lot of it does have to do with being able to get the dilator into the papilla. That's mostly, that's more difficult for the submandibular than it is for the parotid. The parotid is usually fairly straightforward. A lot of the work that I've written on this is with Rohan Walvakar out of LSU, New Orleans. And so, look for papers of Dr. Walvakar. There's a lot of good stuff out there. The saliva itself is very nice to use as a indicator of where the papilla is, but there's not going to be very much if they're in the operating room. Even if you don't give them any medication from anesthesia to dry them up, it's a limited resource. And so be very, very conservative in milking the gland or examining the patient before you get started by, feeling their glands, because you will get rid of all the saliva, and it can be very, very helpful in a difficult case. This is a poster that Dave Kent, he was a resident of mine, he's now at Vanderbilt, as well as Rohan. We wrote a paper about how long does it take to get your camera inside to the ductal system. And what we found is that, and this is in my office, I always have a PGY4 with me. So a PGY4 can get into the vast majority of glands in under 5 minutes. This was a combined experience between the University of Pittsburgh and LSU. On occasion, you may have to do a silodocotomy. The incidence of having to do that goes down over time. I probably do one a year now. And everybody else, I can get the instrumentation into the ductal system. Most of the instruments you're going to need are on the set, and it's not a very expensive set except for the endoscopes. The endoscopes are expensive, and the endoscopes are fragile. They are, it's a 1.1 millimeter glass rod, essentially. So although it's semi-flexible, it's also semi-breakable. And what you have to be aware of is that although everybody, and I don't know if you can see my mouse or not, but although everybody sort of focuses on this part right here as the breakable part, actually this cable that comes into the scope that goes to the lens is a frequent cause of breakage. So people don't pay much attention to this silver cable like the light cable in our endoscopic sinus cases, but that is a common place for breakage. What you see here is an all-in-one scope. An all-in-one scope has, this is the camera, right, coming out here. Camera goes on here, light source attaches right here. This is the working channel, okay? This is a 1.3 millimeter Karl Storz scope, and this is a Karl Storz basket loaded here. There are 2 baskets that they make that can go down that 0.6 millimeter channel. And then this last very small channel is just for rinsing, meaning that if you want to get this kind of picture, you have to stent open the duct by providing a very small amount of fluid that will dilate the duct and give you this beautiful picture of the hilum of the submandibular gland, where it's bifurcating here and there's a large stone right at the hilum. You will remember that most of these stones in the submandibular gland are at the hilum. So that, why is that? People talk about the submandibular gland has more stones because of the nature of the saliva it makes, but also there's a sort of a J where it is involved with the mylohyoid muscle. That also might be why there's more stones in that location. There's a variety of instruments. The more instruments you want to have, the larger scope you want to use. So, you know, for some of these, like the forceps and some of the wire baskets that are made by Cook, they won't go down anything but the 1.6 millimeter scope, or there's a Tinker Toy scope, sort of a modular scope, that also will take some of the bigger instruments. Now that I've just mentioned every company's name, I tell you, I don't have any relationship with Karl Storz or Cook. I do have a disclosure that I somehow dropped on my first slide, which is I have a salivary stent that I make with Hood Laboratories that I'm not going to talk about. The balloon dilators, you know, we'll get into that a little bit more with stenosis, but the balloon dilators have been, you know, plus minus at this point. The one that Karl Storz makes that goes through the scope you're looking at is so small that it almost doesn't help. It tends to rupture before it dilates. And Cook makes one that doesn't go through any scope, that you put just into the system and then watch under ultrasound guidance. That has its own problems as well. So this is an example of a small stone. Oh, not gonna play. Anyhow, it doesn't matter. It's a small stone. What's more important than the size of the stone really is that the stone is floating in the ductal system, okay? So it's not so much a matter of, is it 2 millimeters, is it 3 millimeters, because everyone's duct will be unique. And if this stone at some point in time was lodged more distally in the ductal system, there will be a pre-stenotic or a pre-stone dilatation of the duct, like I showed with that massive dilatation. There could be some smaller amount of dilated duct proximal to the stone. So the main thing you need to know is, can I grab the stone? Will it come forward? And can it come forward enough that I can then easily remove it, even if it doesn't make it all the way to the papilla? Some of the baskets have a tip at the end of the basket, and some of them don't. That involves, you know, where you have to place the basket in terms of trapping the stone. So, you know, with this case, what I was going to show you was a basket that I had actually put the basket in, and you have to go past the stone to be able to open the basket and trap it. And this, I hadn't seen this little opening of the duct proximally, and my basket went in there, and it wouldn't fully open, and therefore I couldn't get that stone into the basket. It took me a while to figure that out. Larger stones, or any stone that's distal in the duct, in the floor of the mouth for the submandibular gland, can be removed just like we in the office, as we've done for, you know, forever. In the parotid, they really pretty much have to be at the papilla to have it be easy to do in the office. So if it's not palpable in the parotid, I don't go making incisions and transbuccally exploring in the office for a stone that isn't right at the papilla. This is a patient who underwent a submandibular gland removal at another institution for infection, and then presented with a neck abscess several weeks later. And it turned out that, you know, they had this big neck abscess because the stone had never been removed. So I see this several times every year where the gland is removed, but the stone isn't removed. And that's either because the stone was in the floor of mouth and they didn't go after it, or the stone was in the hilum, like I said it usually is, but when they're manipulating the gland, the stone is shot forward, and now they tie off the duct. They don't bivalve the gland looking to see if they got the stone. And then the patient shows up with obstruction. So people don't really realize that a stone, even without a gland, causes problems because the duct itself makes a secretion. And so you've got a tied off duct, you know, back here in the neck, and you've got this obstruction here, and eventually this will blow out the tie and you'll have this situation. So that's, you know, several times a year I do take out these kind of stones. So this is what it looks like. Let's see if What about intermediate stones? So small stones, as you can imagine, when we talked about the size of the duct being 3 or 4 millimeters, small stones are about the size of the duct. And those are the ones that will be floating that you can take out. Once you get above 4 millimeters in either system, you have to be thinking about what other options do I have. So one of the options to think about is lithotripsy. However, even though lithotripsy has been around since the 70s for kidney stones and 80s for salivary stones, it does not exist in the United States, and it probably will never exist in the United States. This is some of the data using, there are multiple companies that make lithotripters in Europe. Again, I have no relation, but Stores makes one called the mini lith that's very popular. This is one of the earlier studies on using the mini lith. The thing is done in the office. Obviously, you don't need any sedation. They often get multiple sessions. The sessions last about 30, 40 minutes. Because the submandibular gland makes up most of the stones, more people get this for the submandibular gland, but there's certainly a lot of work that shows that whether you're talking laser or lithotripsy, that the parotid stones are easier to fragment than the submandibular stones. The submandibular stones are harder, denser than the parotid stones. And you'll see that too if you look at your imaging, and you look at Hounsfield units of your CT scans of your submandibular stones and your parotid stones. And there's a paper by Harry Hoffman on Hounsfield units for stones and their likelihood of being fragmented. So this was that same paper from 2008, 31% complete success. A lot of people are better. 14% of them failed and required something else. This is from a huge paper looking at that I showed at the beginning as far as the reference, and you see it below. 4,500 patients, 2,000 of them were treated primarily with lithotripsy. Complete success, 50%. You can see that the parotid was more successful than the submandibular gland, and we talked about that. This was with short-term follow-up. He then published, Eero published a smaller subset of his experience with long-term follow-up. And this is, looking at symptoms and ultrasound, looking for stones. 35% no stones, all the way down to 38% had their glands removed or had some kind of removal of their stones less than removing their gland. So it gives you some idea of where does it fit. If you add these two together, that means 50% of people are pretty good after lithotripsy, as you would imagine. There really are very few events that are of concern during lithotripsy. However, the kidney lithotripsers that are already in our midst, the problem is they're too strong for the head and neck, because a kidney lithotripser is going through your flank, so there's a lot of tissue nearby. There have been cases with people having their fillings fall out from kidney lithotripsers and hearing loss as well. So we don't do that. A nice paper from the UK in 2005 from McGurk showed that if the stone was bigger than 8 millimeters, it's not going anywhere. Okay, so that's using ultrasound, transcutaneous lithotripsy. This is now using holmium or YAG laser for lithotripsy. There's not a lot of literature on this actually, but almost all people who do salivary endoscopy have a love-hate relationship with the lithotripsy device. It is a way of trying to fragment the stone that doesn't involve an incision, but it does take longer. There's injury to the ductal tissue, even though this is a contact laser, so you have to be careful that things don't get too hot. You can hurt your scope doing this because there's when the laser hits the stone, it causes a chemical reaction, and that stuff can get all over your scope and damage your scope. I've done that once. So there are a lot of issues with using the laser, but it does have its. Wonder why none of my videos. All right. Well, let's see. Something to do with Zoom. So what you do with the laser is, you have a relatively large stone, okay, and then you use the laser to fragment it. If you look at a textbook, it looks pretty easy, but not so easy. It is helpful to have a stone that isn't impacted into the ductal system, because you can touch it in a way that doesn't touch the duct and cause a thermal injury, which could lead to later stenosis of the duct. So that was medium stones. Okay, so medium stones, which are our biggest problem. So small stones come out easily with the scope. Medium stones, some kind of fragmentation. If they're large stones, which as you saw, 8 millimeters and up for sure, some people 5 millimeters and up, then some kind of hybrid approach or combined approach. And this was most beautifully described first by Francis Marshall in 2007. So he had 37 parotids, 29 submandibulars, and basically, very high, especially with parotid, but also with submandibular, good success. So for a parotid, what do I do? If I can, you rarely can feel the stone in the parotid from the outside. So what I generally will do is put the scope through the mouth and put the light on the stone, then make a facelift incision, just like you do for a parotidectomy. Leave the parotid in place, don't mess with the great auricular, go all the way out to the masseteric fascia, which is where the duct is, right? So use that as a way to find the stone if you can't palpate it, and then I raise a flap and enter the duct, protecting the buccal branch. So at the end of that, close it with something. I used to use nylon. I actually use Vicryl now because I had a couple of problems with nylon. If the duct is stenotic, you can use a little vein graft. I don't do that. Marshall has discussed that. When you're done, you can irrigate the duct after you've closed the duct and removed the stone, and see how good is your repair. It's probably not going to play either. Okay. All right, so why do you need a scope at all? Well, not all stones are palpable when you do these hybrid approaches. Sometimes the stone will move during the procedure and then you don't know where it is. It's stressful enough with a scope, so I would think about it that way. It is certainly a safe, effective way of dealing with these large stones. And in fact, most of the larger centers in the United States are more likely to use a combined approach to the parotid or a combined approach to the submandibular gland than they are to use a laser. So laser has a very small role currently. These combined approaches where you make an incision and remove the stone without removing the gland, so it's still a minimally invasive technique, are much more common for the large stones. In the submandibular gland, if the stone is palpable transorally with bimanual palpation, then you can remove it with a incision by the second molar posteriorly, and then dissect down, move the lingual nerve off of the duct, make an incision in the duct, and take it out. You see that, looking at a small series of our patients at the beginning, 40 of them were successful and 5 of them failed. And you see, it's not all about size. We had some very large stones that were successful, and we had some smaller stones that were failures. So it's about shape, location, inflammation, the body habitus all play a role in who's going to be affected. So this is my algorithm, my overall algorithm of how I approach stones. People worry about like, oh, this stone is too big to come out. Actually, these stones are the easiest thing to do. You can palpate it in the posterior floor of mouth. You make an incision. Often with the very large stones, the lingual nerve has already been displaced laterally by the stone, and so make an incision right on the stone, delivering the stone. And then at the end of that, how to repair it. There are lots of studies that show that you don't need to do a ductal repair. So we just put a couple of sutures in the mucosa of the floor of mouth to close these. If they fistulize into the parotid, at the end of if you took this stone and you took it out through a facial approach and they leak here, that's a problem, right? To get a sialocele. But if you take out the submandibular stone and they get a fistula, doesn't matter. So, all right, so that's stones. Now, people think that's all you do is stones, but actually a lot of patients come to see us that don't have stones for their pathology. So I'm going to just touch on a couple of other indications for using the scope while we have time. And about 50% of patients who come with obstructive histories in their parotid gland, which means that when they eat, they get parotid symptoms, will have non-stone obstruction. And it hasn't been that long that people have been talking about that. As I told you at the beginning, there was a time where all of these stenotic people were just called non-imageable stones, right? But what they didn't realize is that what they really had was stricture. It wasn't that they had a stone that was too small to see. It was that they never had a stone. So this is some of the better papers out there. Obviously, until you get into the 2000s, you don't really have endoscopic approaches. This paper is out of Nalili's group in Israel on treatment of stenosis. More common parotid, less common submandibular, the opposite of what we see for stones, and he has 10 years experience. Here's one of his papers on using it in Stenson's duct, 149 stones, looking at this group of patients, but 26% had strictures, and most of them had symptoms either continually or greater than 4 episodes a year. So salivary endoscopy and his hands under local, I often go to the operating room with the residents and do them either sedation or general. If he couldn't improve it by just passing the scope through the stenosis, then he had a company that he founded in Israel that had its own balloon and its own stent. That technology has been sold to a German company now. I don't think he's involved with it anymore, but there are a variety of companies that make different products. His paper, the stent was maintained for 4 to 6 weeks. I would say that's much longer than anybody in the United States does. This is a video of what a stenosis case looks like. So you see there's no opening. We're actually looking at the duct. There's no opening. I'm trying to see if I can even get a guide wire to go through this little area. I get the guide wire through, I get the scope through, and now you see, now that we're on the other side of the stenosis, how we have, we've entered into a huge dilated cavity because it was so tightly stenosed that everything proximal is dilated. So that's, that can be done with a variety of techniques. Sometimes if it's very mild stenosis, you can just use saline. There are drills that people use. I actually use the scope the most, majority of the time. Marshall uses the modular scope because it doesn't put as much pressure on your scope. But there are other ways to do it. But if you're very careful, using a scope is a reasonable way to go. The patients who do best are these patients that have a point single diaphragmatic stricture. Okay, sort of like our case here. If you look back here, back at the beginning, you can see where the opening is, just a single very, very tight stenosis. Those patients are almost always a home run. All right, what about radioactive iodine? Well, radioactive iodine affects your saliva glands. Why does it do that? Is because the sodium iodine symporter on the cell membrane is the same for the thyroid and the salivary glands. So your salivary glands take up radioactive iodine, and then generally about 6 to 9 months later, we see a subset of patients who get radioactive iodine who start having fairly intense salivary gland symptoms. And there's been discussion about how to mitigate that. We're obviously doing less radioactive iodine. The doses are smaller, but for people who get frequent, more than once a dose, and who get over 100 millicuries, this can be a real problem. The symptoms they get are generally as you would expect. Don't forget that the lacrimal glands also take this up, so they do end up with dry eyes. but the dry mouth bothers them more. There's a natural history of resolution of that, so that over a 2 to 3 year period, there will be a number of patients who just natural history will have some improvement in the dry mouth and gland swelling. But there is a percentage of people that don't get better, and they're amenable to salivary endoscopy. There's some very small studies, I mean, really small. This was one of the earliest ones for radioactive iodine, this one out of Korea. They had 6 patients, 3 they used the balloon, 3 with debris, 100% success. This was a paper we published in 2009, 12 patients. Again, we had 32 glands because multiple glands can be involved. So even though there's only 12 patients, we had about a year and a half follow-up, and 84% success. Symptom relief, 75%. Isley had a paper, I think it was when he was still in San Francisco. Again, small paper, 11 patients. One of the big differences with the Isley paper, and the reason I put it in here, is almost everyone else, after they irrigate the gland and dilate any stenotic areas, most people put Kenalog through the salivary scope into the gland as an anti-inflammatory. But Isley didn't. Isley didn't put any medication. He just irrigated, and he had pretty much the same success as everybody else. So, when you see that for anything, whether it's endoscopic sinus or what have you, it means that probably a lot of people are overdoing it. Just like what you see with a lot of what's going on with COVID response to what should we be doing. There are a lot of people who put out philosophy, but philosophy is not fact. So I'm going to sum up, and I think I'm right about where I should be. So salivary endoscopy has been around a long time. Took me a long time to be able to become a practitioner. I think it's very fun. It's by and large done by head and neck surgeons around the country, although it sort of has an otology feel to it. Tiny little openings, a gentle technique. But because the complications and the rescue procedures are more head and neck like, I think it does generally fall to a head and neck department person to do it. It's been FDA approved since 2005. It's minimally invasive, gland sparing for inflammatory disease. Although we talked about stones and stenosis and I-131, some autoimmune disease like that we use it for. We use it for Sjogren's syndrome. There's, as you know, there's a recurrent pericarditis of childhood. Because I'm lucky enough to have a beautiful children's hospital walking distance from me, the practitioners in my practice who go to children's do our pediatric care. So I do very few of these pediatric cases, only, if somebody has it into their teenage years and wants to see me. And with that, I'm going to see if I can figure out if anybody wants to ask a question. Brett.
Yes, sir.
How you doing?
I'm good. I'm monitoring the chat board and the Q&A, and no questions on there first. So if any of the viewers out there, if you have any questions for Dr. Schaitkin, please share them. I do have a question for you though, and pardon me if you cover this because I had to step out briefly for something else while you're talking. But where do you see this going in the future? Do you see sinus cases all the time? I'm thinking, man, if I just had this instrument that could do this, that'd be the next level. So do you see any kind of advancements coming that you can imagine with this equipment?
Yeah, so nice question. In terms of the future, when I look at the huge need for minimally invasive technique, I would say xerostomia is the huge need, right? I mean, we're pretty good at obstructive pathology. So what we need to see is, will it be possible to do something like for head and neck cancer patients who are going to get radiated, could you put something into the duct that would protect the gland? There's been work with this thing, amifostine, kind of all over the map, but it doesn't mean we have the right tool right now. but could you be putting something into the gland that would take our head and neck patients who obviously suffer tremendously from their xerostomia and the dental effects and the dysphagia and all the rest of it. So that I think is huge. Along those lines, there are a lot of centers that are doing stem cell research, salivary stem cell research. Again, could you take somebody who has Sjogren's or radioactive iodine and inject stem cells through the scope and create a working population that provides saliva function? I think that would be very, very exciting. So I think the platform is there if we could come up with the right agents to give relief. I would say for the saliva community, xerostomia is the most miserable patients we see. The stone patients are so fixable, and there's so little of any real value that we give our xerostomia patients that that for me is the next frontier.
It's fascinating stuff. All right. Anybody out there have any questions for Dr. Schaitkin before we let him go on? I'm not seeing any listed, Barry.
Okay.
We really appreciate you joining this consortium as well. We've had a few lecturers over the several weeks that have done all three. And so just really appreciate kind of the community of otolaryngology coming together with all these consortiums. And I agree with you. We're trying to some trial and error things between the consortiums to figure out what seems to work well, what seems not to work well, and hopefully we can keep this ball rolling forward in the future in terms of national platform sort of thing.
There's no question that the residents love it. At least my residents love it. The ability to take a videotaped so that the time zone becomes less important.
Yes.
Once everybody gets used to the it's hard for the faculty is finally getting used to the platforms.
Yeah.
Since we're all doing way too many Zoom meetings and team conferences, I think, and telemedicine, everything is going to be moving in that direction. So I think it's just great. I could see this as being a nice way to have residents who are having a problem case, just put it out there and get feedback from all over the country. A forum like for difficult rhinology cases, difficult salivary cases where, on Friday afternoons, there'll be, hey, bring a case, de-identify a case, bring it and let's just talk about it. Yeah. I think that from a resident standpoint, this could just be that something that they could, independent of us, that they could promote and say, okay, I'd like to have a resident team chat once or twice a week, different topic every week. People bring cases, we'll talk until we get tired. It'd be a nice way to spend the end of the day. And, to be able to have someone like yourself or, Rob Jackler weigh in on a case, and here you sit in Pittsburgh, or, Amber, talk to somebody about a sinus case. That doesn't really exist right now.
Yeah.
But that is what can come out of this horrible thing we've all been stuck in the quagmire of, is that it could make all of our lives dramatically improved from an education standpoint. Yeah. So thanks again for putting it together.
Oh, you're welcome.
A safe and happy day. And yeah, we're getting back to work in Pittsburgh too. We're starting elective surgery today in a slow rollout.
Yeah. Yeah. Well, thanks again, Dr. Schaitkin. I really, really appreciate your help. And just for the viewers, tomorrow, let me pull my list up here. Tomorrow, we're actually going to start at 9 a.m. We're going to start out with some speech and language pathology and pediatrics with Dr. Davis and Dr. Sommer from UTMB, when to refer and the role of the speech and language pathology and pediatrics. And then we're going to talk about some audiology with Dr. Nahuli from UTMB, persistent dizziness, and then we'll end the morning with Dr. Dejalian from UC Irvine talking about facial nerve electrical testing. So we will see everybody tomorrow at 9 a.m. Eastern time. And thanks again for everybody participating. All right, Sarah Lynn.